Blue Cross and Blue Shield companies are committed to maternal health equity. We're advocating. Blue Cross and Blue Shield companies are committed to maternal health equity. We're advocating for better care at every stage of pregnancy. We're working to ensure better, standardized data collection. We're embracing the vital roles of doulas, midwives, and community health workers. We're helping create a diverse workforce of care providers. We're determined to create a better system of health, one that is equitable, one built on trust. Because healthy communities need healthy moms.
So Matt and Doug went to high school together. They were friends, right? And so, so Doug, so Matt, Angela and Jeff started dating before I was on, like in '97. Because she was straight girl, and I was straight girl. Jeff's my big brother. Okay. Whatever. My special, my number.
Yeah, I never connected with the Kappas at A&M that hardcore. Because I was dating an Alpha. So, what's his name? Brian. Yeah.
Oh, tall, like Brian.
Yeah.
He's from Houston, right?
No, he's from, I feel like from Louisiana.
I don't remember his family from, but I know you're talking about. Yeah.
I can't remember exactly.
All right. Let me get everybody. They are. They're all sitting down. No, you're here. I'm just gonna get you. So they're gonna put.
Blue Cross and Blue Shield companies are committed to maternal health equity. We're advocating for better care at every stage of pregnancy. We're working to ensure better, standardized data collection. We're embracing the vital roles of doulas, midwives, and community health workers. We're helping create a diverse workforce of care providers. We're determined to create a better system of health, one that is equitable, one built on trust. Because healthy communities need healthy moms.
Good evening, everyone. Everybody's getting fed, getting full. How was your day? You enjoyed the day? Tiring, but I learned a lot. I'm here to sort of start the introduction of the town hall, but I want to make sure that I gave a proper shout out to a good friend of mine, Ashley Etienne, who came and supported us. You may have seen her on, Meet the Press or CNN or whatnot. So I just called her. I was like, hey, it'd be great if you could do a town hall. Can you help me out? And she's like, I'm a little busy. I was like, but I just, I leaned on the shield and the friendship. And obviously, she's known as the Queen of the War Room. She's worked as Queen of the War Room. She's worked as the communications director for both Speaker Pelosi and Vice President Kamala Harris. She worked for President Obama. She worked for we worked with Biden, his vice president. So worked for President Biden as well. She's done a bunch of amazing things, but I have to remind her how we met. We were both interested in our respective fraternity and sorority organizations, and we were both tasked by the older people in our fraternity and sorority to pass out flyers. And so that was in a few years back, 1900. And 30, yeah. And so I'm glad that she's gonna join us today and lead the conversation. And the good thing about Ashley, you're gonna know, is that she's always honest, because she reminded me that I was always Ashley at one point, and to take care of myself. So I'm gonna go ahead and turn it over to her and let her lead this discussion.
Thank you. Well, welcome everyone to the town hall. I'm excited about this conversation. We've got some incredible leaders across the region that are going to give us some perspective and clarity on the challenges that we're facing as it relates to health equity and an array of other health challenges that we're facing, and really how they're tackling those challenges and how they're leading to address those challenges. And then at some point, when I exhaust my sheet of questions, I'm going to open it up to you guys, so you'll have the opportunity to really engage them as well. There's mics in the back, but when we get to that part, I'll make sure I flag it for you, and hopefully you guys have been thinking through some really good, tough questions. But I've already forewarned them that I'm trying to make a name for myself, so these are going to be some hard questions. And I'm just joking. All right, so I want to start by introducing the panel, if you don't mind. I want to start with you, Dr. Bennett. Okay, don't get shy. I'm going to run through your credentials here. You've earned them all, right? You're like, I'm good. Board certified internal medicine physician and pediatrics. Sorry. Am I reading the wrong bio? Oh, okay. Well, listen, I'm gonna blame it on Brandon. I'm not. Okay, so she's a pediatrician, my favorite types, and definitely not preventative medicine specialist. All right, so that was wrong. But Dr. Bennett focuses on health equity, addressing social determinants of health, and modernizing public health systems. Absolutely, that's you. Thank God. She holds an MD from UC San Francisco. Now I'm looking at you like, correct? And brings extensive clinical and public health leadership experience to this particular discussion, and mostly on evolving roles of public health agencies. Thank you. Can we give Dr. Bennett a round of applause? Can I call you Secretary Figueroa? Yes, is that okay? Okay, since you're the only non-doctor on the panel. All right, but listen, I'm gonna read through your bio. Let me know if it's accurate, okay? Leading Virginia's Health and Human Services portfolio under the new governor, Spanberger, overseeing agencies serving individuals and individuals with disabilities, older Virginians, children, low-income families, a native of Honduras, and a Posse Foundation scholar. Figueroa champions access vision, advancing community care and environmental sensitive standards. We're gonna have you break that down for us. And holds degrees from Vanderbilt as well as Harvard University. So let's give it up for the secretary. Dr. Seisha Mani is the secretary of Maryland Department of Health. She's a physician, health economist, and a Rhodes Scholar overseeing Maryland's public health infrastructure, Medicaid program, and healthcare delivery systems. That's right. Okay. She's like, you're really giving me a look. I was like, is that right? Previously served as Deputy Administrator and Director of the Center for Medicare at CMS in the Biden administration, overseeing policy for 65 million Americans. Incredibly impressive. She holds an MD from the University of Pennsylvania, a PhD in health economics from Oxford, and a BA from Yale. So please welcome all of our panelists. No? Not Yale? Okay, it's all good. All right, listen, Brandon is to blame for all of this. All right, but here we go. So let's really jump right into it. Everyone have their mics, right? Everyone's prepared? Okay, so if you step back, this region, I'm gonna call it the DMV, obviously, is dealing with overlapping crises. Overdose, mental health, maternal and infant health, and chronic diseases that are deeply tied to where people live and what they have access to. But resources are finite, but leadership is also a focus. So I want to ask each of you, what is the one issue that you believe demands the most urgent attention in your jurisdiction right now as it relates to these crises that we're seeing across the region? Dr. Bennett?
So I wish we could urgently address everything on that list. I have to say the thing that is keeping me up is the changes in Medicaid and benefits that are happening so quickly.
Mm-hmm.
Government's a big ship. It generally doesn't turn quickly. So for us to make big changes like this that are happening on the exchange and in Medicaid and in food and benefits all at one time, all within the course of 6 or 7 months is, I'm not sure, possible to do well. And so the estimates so far about the number of people who will become uninsured concern me, the number of people who won't have food benefits, and mostly because we have lived in that world before.
Mm-hmm.
I got trained in that world where you have cancer, but you don't have insurance. We had structures to manage that were all dismantled when we decided we were going to give everybody health care. So charity care from hospitals does not operate the way it did 20 years ago. We don't have some of the financing mechanisms we had. The donor bases from healthcare delivery on the philanthropy side are mostly doing other things. Just the number of free clinics that are trying to operate without federal dollars, we don't even do that anymore. So the infrastructure to manage that world is gone, and yet we're coming to live there again. So I am frankly worried that all of those problems are going to be exacerbated by this big one.
So dare I ask, so what's the solution?
I don't know that there is a total solution. I guess we could ideally change our mind and not do some of this. But for now, we are doing what I think of as triage. So in DC, we started a basic health plan program that basically put a plan on the exchange that was a $0 Medicaid lookalike as much as possible. Can't do it exactly. Ambulances aren't free in private healthcare. So as Medicaid lookalike as much as possible, and then just auto-populated that with everybody over 133% who was going to be kicked off of the expansion, with the expansion population. So that's 16,000 people who didn't hopefully fall in the gap, but that's not going to be everybody. It's not going to do anything for the food assistance. That's work requirements are going to eliminate for folks come June or July. It's not going to do anything for our legally here immigrants who are about to lose care and food and lots of other things in October. So I don't know that there is a way. I've been talking to every philanthropic organization I can think of, and absolutely all of them say we can't backfill the federal government, and they're right, they can't. But neither can the local government, neither can the state.
And neither can families.
Right, nobody can backfill the federal government. So when you have a structure and you take a leg away, I don't know how you solve for that, but we're doing whatever we can.
Dr. Shamani?
Yeah, thank you again for having me. And it's so great to have the DMV here together.
Exactly.
So I think I would say the thing that concerns me the most, and where I am focusing a lot of my efforts and where I am putting my body, there, is the sense of mistrust, the sense of uncertainty or even chaos, the sense of anxiety that our communities feel. So when the examples that you gave about maternal child health, right? I visited we have WIC under our department. I went and visited one of our WIC facilities, right? Doing amazing work, helping people before birth, after birth, encouraging breastfeeding, healthy food. And the number of women who are leaving their houses to go to the clinic has gone down because people are afraid to leave their house because they're worried about what might happen to them. Another example you mentioned on behavioral health and overdose. I think that our country had made a lot of strides in terms of addressing the stigma associated with behavioral health, and we're seeing now that things like harm reduction are somehow being seen as not good, and what that means for us being able to meet people where they are, and for people to feel safe that they can come as they are and be taken care of and be supported. To give the example of Medicaid, the amount of confusion and anxiety that exists around people right when the law passed thought they no longer had health insurance and weren't going to get care. And the amount of effort that it takes for all of us to meet people where they are, be like, we will hold your hand, we will walk through this with you. And then I think where it gets talked about a lot is public health, right? Vaccines, as an example, where, really I think it is incumbent on all of us to say, okay, how do we meet people where they are? How do we help them to make sense of the chaos? How do we help them to feel like there are people who really want to help and want to take care of them? We're in it with you. We've got your back. And that's some of the work that we've been doing also on the vaccine front to try to, give better information and provide, kind of that thoughtful joyful, because taking care of people is joyful. Way to navigate through all of this uncertainty and chaos, lack of trust and anxiety that really has permeated, I think, every fiber of everyone's being.
Absolutely.
And all aspects of our lives.
Absolutely. I want to, if you don't mind, get back into this issue of vaccines, skepticism, and really how vaccines have been politicized over time, and how you're sort of combating that and this issue of trust. But I'd love to get back to that if you don't mind. But Mr. Secretary, I'd love to get your thoughts on what do you think is demanding the most urgent attention in Virginia?
Well, good evening, everyone, and thank you, Ashley. I see you on TV all the time.
Thank you.
I will have to say the instability as well around the implementation of HR1, the big beautiful bill, OB3, and if you are colorful enough, you name it other things. And it is the breakneck speed in which we have to implement a lot of these provisions. You look at the reduction in federal support. You look at the fact that we have to implement a work requirement that I think is going to lead to more people being uninsured, not necessarily because they're ineligible for Medicaid, but because the level of administrative complexity that you introduce to the system means that people will no longer have that coverage. I'm concerned about what that means for our localities. Like, we know where we are likely to find the folks who are most likely to be uninsured, and those are the most low income, research poor communities in the Commonwealth. So when you think about the progress we made over the years around maternal health, around behavioral health, that is the progress that is being threatened because of what we're seeing in the federal level. I will say too, you can't replace the dollars, right? So we were chatting earlier, Virginia received $189.5 million of the Rural Transformation Fund, but that doesn't replace about $1.6 to $2 billion that we're losing. To borrow from my sister, the math ain't mathing, right? And so we have to figure out in this kind of environment, how do we maintain those services? How do we deliver those services? Because the need is still there, but the resources are no longer there.
So what's this? I guess I'm gonna have to keep asking the same question. But what's the solution? How do you fill the gap?
The solution is that the bill passed, and we have to implement it to the letter of the law. But we also have to infuse our values in how we implement it, right? And so, take, for example, work requirements. The work requirements are what they are, but you don't have to do a lockout period, right? So rather than keep people out from insurance because they're not compliant, you can make it as easy as possible to make sure that those individuals can show compliance and be re-enrolled. When you think about the fact that there is there's exemptions, how do you go through the exemption list and make sure that you are exercising every possible exemption is another part of the solution. When you look at the folks that have to comply with those requirements is, how do you ensure that you're working with the Department of Commerce, you're working with all your workforce and your community engagement support so that those individuals have the skill sets to be able to go in the workforce and be compliant. And so it requires an all-of-government solution in a space where government tends to be very vertical and very fragmented. So we have to reimagine even how you engage within the government, but it's something that we are doing in Virginia.
Thank you for that. I mean, we talked a lot, each of you talked a lot about resources and the need for resources obviously being tight as the federal government has shifted a lot of its priorities, and Congress is, to your point, passed the big beautiful bill. I'm just curious, when you look at your top priorities, whether some of the issues I've named, overdose or maternal health or chronic diseases, how much of these solutions do you think is by virtue of the healthcare system, or is more dependent on addressing the conditions that people actually live in?
I find that dichotomy so difficult. So there is no hero in that story about watching the people go downriver and you're supposed to go upriver. You better hope there's something upriver you can do, because you decided you're going to let a bunch of people drown.
Yeah.
So I don't want to be either of those characters in that book. We absolutely have to take care of the people who are sick right now. That is a moral mandate that I don't think we can get past. We had made so much progress. I actually have a little bit of grief about this, because we made so much progress in understanding social determinants, in moving people to think those were a thing they should worry about, into actually getting some structures behind moving those things. but I have a hard time thinking that's where I can put a lot of my time if the person is actively drowning in front of me.
Right.
So in an environment where I have potentially thousands of people at least, if not more, probably more, who are suddenly going to be without food or suddenly going to lose their health care regardless of their health condition, because we're going to have to figure out how to use that exemption because there is not a great definition for medical fragility. I don't know how I don't do that. So I am hoping that I am confident that we will not lose all of the progress. You cannot unring the bell. There's a whole generation, everybody in the workforce was impacted by that shift. And I think no matter how much there is some hope somewhere that if you just make it be quiet, that you can undo it, they are wrong. You cannot undo it. There are too many of us. Too many of us in too many positions of power, it's too late. But at the same time, we are going to be hampered by having to get in the water and pull some people out for a while. And I just think that's what we have to do.
How do you bring, I mean, you're about to go through a transition of mayors. How do you bring your curious, because I've been in those rooms, how do you bring the principal to the table to understand what you just laid out and really have that inform your priorities?
I don't think I can do that alone. I have been chasing philanthropy for about a year now since things got so chaotic. I'm like, y'all got to come to the table. And we had a meeting just a couple of weeks ago, and one of the things that they came up with as a thing that they should do to help is to find all the candidates to make sure they understood that this is going to be a bad year, and you guys need to pay attention. This is not a thing to play around with. You're going to have hit the ground, and how serious it was going to be. Because I think if you are not paying attention, if you're not actually in the field, I think people have absorbed a lot of anxiety, but not a lot of information.
Sure.
And so that is not the position at which you solve problems.
Sure.
That's the position at which you get nothing done. So trying to help, having people in, I think, healthcare, philanthropy, and others really start to circle around those people with influence who may have thought they were other things they could pay attention to let them know that this is going to be a healthcare moment, I think is really important. And I appreciated that suggestion.
Doctor?
Yeah, so when you say, is it like the healthcare, I think it really is both.
Yeah.
And I think we absolutely need to move past the silos that have kept healthcare delivery and public health separate and take it even one step further to integrate the work we're doing with local economies, the health of local communities. So, I think piggybacking a little bit off what Dr. Bennett said, I think that we have, for example, in Maryland, we have our payment model, which is unique. We are able to take some of that money that would be spent in a hospital and instead invest in population health. So we actually have just rolled out a food as medicine program in 6 counties, which we know that for people with diabetes who get admitted to the hospital, who are hungry, food insecure, providing them with medically tailored meals ends up improving their blood sugar levels, prevents emergency room utilization, prevents hospital. And we should be funding that just like you pay for that trip to the hospital. And so this is some of the work that we're trying to do, and I think it extends even further into the communities when we're taking our rural health dollars and we are investing in our local farms for cold storage and food aggregators and distribution hubs, so that when you are having healthy eating and healthy foods and medically tailored meals, where is that food coming from? It's coming from the local community that in Maryland is engaged in regenerative farming to decrease carbon footprint, nutrient-dense foods. And thereby, you're also not only helping people at that healthcare end, but we all know that what is the #1 cause of poor health? Poverty.
Right.
And so being able to, we are at that moment, to your point, of this is the moment in healthcare. It is time for us to think beyond our playing a game of whack-a-mole, because there are lots of moles coming up.
Right.
And so how do we think about how we can garner the energy that we have with all the things that are coming at us? I use the word things because I'm not getting creative. But how do we harness that to be able to really solve problems together in our communities? And I think that's where we need to head.
Thank you. Mr. Secretary?
I agree.
There we go.
Easy answer.
Easy
Give us
answer.
more. Give us more, okay?
It is that. I think for us, it has to be both.
Yeah.
You can't turn away someone who's in an emergency room, needed care at that very moment. So making sure that that safety net remains strong enough. I think the hard part about this new environment is, I was in Virginia during Medicaid expansion, and we all rallied around this goal of getting more people coverage. And we got about 530,000 Virginians covered. This is a different situation where you're trying to prevent something bad from happening. Knowing that regardless of all the efforts that we make, there are going to be about 100,000 plus Virginians who are going to lose coverage. So it is, how do you mobilize these resources to tackle both the immediate, but also think long-term so those folks never have to show up in an emergency room.
Right, and it seems like, my question to you is, what do you sacrifice? And maybe you don't have an answer to it because we're in the middle of it and we're still at the mouth of it. But I'm just curious, do you sacrifice the preventative, creative, innovative work? Just curious what your thoughts are on that.
Look, and the biggest misconception is the governor has all the power.
Has what?
Has all the power, right? So you're dealing with council or you're dealing with the General Assembly of Virginia's case. And I will say that right now, rather than thinking about what we sacrifice, is like, what do we look at through new lens? So especially technology, right? So how do we think about, how do you deliver care remotely? How do you think about using paraprofessionals more creatively? The incentive for most emergency transport is to get the person to the hospital. What about if that emergency transport actually stabilizes that person so they never get to go to the hospital because that person is trained to be able to deliver services at that point of care? So you have to look at it that way.
Sure.
And I will say that one of the biggest challenges is within government itself.
Yeah.
So how do you get your own secretariat, right? So how do you get, I'll take a pregnant person as an example. That person gets Medicaid. We know that person is pregnant because they have Medicaid, so they go to the physician. But we never had the trigger to then say that person should also get WIC. Or that person should also, when they touch our behavioral health agency, should also be getting behavioral health services to avoid postpartum depression. That person should also probably get SNAP that happens in social services. So there's no case management on an enterprise level to ensure that we're reaching those efficiencies so that we can take those savings and invest it somewhere else. So we're not at the point where we're sacrificing just yet. We have to think creatively as how we work together within our own secretariat.
So I'm just curious. You only have 4 years, which is a ridiculously short amount of time to achieve just about anything. So how do you think about, to your point, innovating while managing the crises that's in front of you in such a short period of time? And again, we don't really know what the impact, you may not feel the real impact for another year. I'm just curious how you are squaring all of that.
Yeah, I think part of it is you can't come in trying to boil the ocean, or by doing that analogy, you don't try to fish for whales in every situation. I think if you bring your agencies together and have a conversation about what are the things that they see that they feel they could better collaborate on, or what they see as things that they want to do but couldn't do that will improve X, Y, and Z, you get really good ideas from your agencies. And then you're creating the space for those agencies to have the time to be able to think creatively.
Sure.
Because on a day-to-day, they're trying to figure out how to deliver core services. So at the very basic level is, we have 4 years, there are already good ideas there. What do we scale? And what do we decide to either reform, or what do we minimize, or what do we eliminate altogether because it's not working? I think the challenge with government sometimes is there's not a robust research question that we're trying to answer, nor there's any evidence sometimes. So if you want to make anyone nervous in government, ask them what they could stop doing.
Yeah.
Right, and so those are the questions that we're asking in Virginia.
I would say, first, the one positive to the chaos that was last year's relationship with the federal government is that it did push nearly everyone to do some planning. So that question I got asked at every convening of more than 2 jurisdictions for a whole year. What can you do without? What will you do differently? And I feel like we arrived at some answers. I know if I had to, because they threatened it 50 times, if I had to decrease HIV prevention, I could shrink that program by about 50% and focus it just on the highest need and feel like I was still doing something. I know that for a bunch of things now. That does not cover the waterfront, right? That doesn't fix the problem, but it does prevent the worst of the disaster. And I know what that essential core is for everything, because I had to know, because it looked like I was about to lose everything. So that is a good thing that we know that. But I will say, for me, the approach is that we push that question down and down so that people are looking for those, I won't say efficiencies, because really they're innovations. How do we get outcomes and benefit with what we're doing and that we actually have control over?
Right.
So I used to be the chief health equity officer in San Francisco, and I would always have someone tell me we needed to fix poverty or whatever. And I'm like, that is what you can protest for on Saturday. On Monday at work, what are you going to do?
Right.
And that is the question I still ask everybody. And so then you get projects that are less, maybe less mind-blowing, but actually get something you can feel. So like, for example, we got the social work test had some real racial problems with it. We got a lot of advocacy, and we just eliminated the test and replaced it with an alternative competency. Essentially, you spend the first two years of your career having someone document your competencies. Can you work with translation? Can you do whatever? That the test at least said it was supposed to be testing for. We've had a few hundred graduates of social work come now apply for licenses. Almost all of them are Black. And that is not, we did not have an overabundance of Black social workers. So we are fixing a disparity problem without investing in a new program. Because I got rid of it's addition through subtraction. Like, what's my problem? And there's plenty of things we could do that way. So it's forcing people to really think, where are we the problem? What lever do I actually have control over? And how can I use that lever? And we make laws.
Yeah.
So we're not powerless. And how do we use that and our partnerships and philanthropy and all those things that we're capable of at the level of government that other people can't do to really move the needle, and then challenging people to move a needle, not just talk about something.
Dr. Sishimani, would you like to ask?
Yeah, I mean, I think what you're hearing is a theme that it's not an either or, that you address the crisis or you innovate.
Right.
I think you actually can address the crisis by
Innovation, absolutely.
And crisis can be an opportunity. It's like apocalyptimism. Have any of you heard that word? That's the word that I'm using for the time we're in. Apocalyptimism.
Write it down.
I like
How do you spell it exactly?
Yeah, I mean, when I heard that, I was like, that's it. That is what is getting me through my days.
Yes.
But, I'll come back to the example that both of you gave with HR1, the big, beautiful bill. One of the big issues for people is navigating our complex system.
Absolutely.
Right?
I
Now,
can
when you
attest to
look
that.
at the work requirements and what is put in place by this law, when you look at the examples of Georgia and Arkansas where they implemented work requirements, what's the number one reason that people came off Medicaid? It wasn't because they weren't working. It was because they couldn't get through the bureaucratic red tape. And so we have an opportunity in this moment to make it easier for people to navigate the system. So like we in Maryland are leveraging, we have a one application platform for SNAP, for LIHEAP, TANF, Medicaid, and we are leveraging that to bring in, for example, the National Student Data Clearinghouse, to bring in information on wages, to link in to our electronic medical records so that as much as possible, we can automate the work of people having to prove their eligibility for Medicaid so that people don't have to do that. And honestly, that's something that we should be doing anyway.
Yes.
This has given us that like kick in the pants that like, okay, it's now or never, we have to do it right now. And this is something that people have been talking about for a while that would be good to do. So, kind of thinking about where there are those opportunities, like to your point, I also had my teams go through, okay, what are the programs that we have? Where is there duplication? Where is something not really working? That is generally a good exercise to do because resources are limited, even more so now, but even in the best of times, you want to put your effort where they're going to have the most impact. I think anybody in public service, anybody in healthcare, all of you, right? You want to put your shoulder to the wheel where you're going to be able to have an impact. And this moment just calls for that, perhaps in a chaotic and, disastrous kind of way at times, but at the same time is still coming back to that fundamental that I think is really important for all of us.
You've worked as a deputy director at CMS, so you've been in the system and run the system, and now you're running the health department in Maryland. How do you, with so much anxiety, get your team to focus on innovation? It feels, it feels so, the problem feels so overwhelming. And, in a lot of these agencies, you have sort of holdover, I would assume, like you do at the federal government, people that are sort of career. And I've always found those individuals to be the hardest to move without good leadership. So I'm just curious how you're tackling internally, creating an environment for people to be creative, to adopt a vision and, become visionaries where there's so much anxiety, so much uncertainty, and people feel overwhelmed by the challenge.
I mean, honestly, I think it all comes back to seeing each other as fellow human beings, right? I mean, so I started doing mornings with Mina where people sign up and we get together and have coffee, tea, sometimes donuts. Don't tell anyone, Secretary of Health giving donuts. But, like just chances for people to get to know each other. And in those conversations, like you find collaboration and new ideas come about. Or as a department, we do coffee and donuts in the, in the lobby. We do regular town halls. And all of that builds to, we have strategic plans for each of our administrations and for the department as a whole that come from the staff, come from the team saying, okay, what are the things that matter to you? Where have you seen your efforts really take root? And how do we amplify that? And so I think really that's how we've been doing it. Like I will be the first to acknowledge that we are in really, really tough times. And I want there to be a space for, and it may be with me during one of the mornings with Mina, it may be peer-to-peer, it may be people talking to their immediate supervisor, but I think it's important that people feel that there is a space to be able to process what's going on and then realize that they have the power and the ability and the knowledge and the expertise to do something about it. Like the ideas all come from them. So I think that's kind of how I at least have tried to approach it.
That's awesome. You want to add something?
I would say I take two approaches.
Okay.
One, I give people awards. So I give innovation awards.
Nice.
Partly because there is always somebody trying to do something in a department, not necessarily being lauded for it, but they will tell you if you go ask. So I give awards for innovation every quarter, and we give a big one at the end of the year. The other is I want people. A lot of innovation is problem solving if you do it right. And so one of the things we're doing to try to get people to listen to constituents and then fix that thing is in the newsletter and at meetings we do, you said we did. What did people complain about? And then what did we do about that thing? Just you said we do this. You said we couldn't get social workers, so we changed it. And so that people can see that direct line between the problem and then what they did. Because so much of that difficulty in getting people moving is that it all becomes so blah and routine. And they don't feel the impact of their work anymore.
Mm-hmm.
And so trying to move that back to the face of the person who is telling you, I could not get what I needed. And then you say, but now you can.
Mm-hmm.
It plugs back into that bleeding heart, love for people that got all of those folks in this industry anyway.
Yeah,
there are
absolutely.
other places to work. There are
Absolutely.
easier things to do. They're here for that. So you have giving them that sense of purpose and that fire again. I think you have to close the loop.
Yeah, and it's so necessary, especially now in this environment. So across the region, we're seeing the same pattern. Your zip code, your race, your income still determine whether you live long, have a healthy birth, survive chronic diseases. What would you say is the one intervention you believe could most quickly close the gap? And then what would make efforts sustained and sustainable, if that makes any sense? So Dr. Bennett, for example, what's, you know, in DC in particular, we're not talking about marginal differences. If you look at, you know, Ward 7 and 8, for example, the life expectancy is 72. You look at Ward 3, for example, life expectancy is 87. So within a matter of miles, you're talking about a 15-year difference. That's just one of sort of statistic that popped out at me, but I'm curious, what do you think is sort of the quickest intervention to close some of these gaps that we're seeing across the district?
I'm not sure. I think there's a quick one, unfortunately. If you get it down to the neighborhood, it's up to 20 years.
Which is
So
insane,
it is
It's
insane.
unbelievable.
And part of that is that the reason I don't think there's a quick one is I don't think it was quick getting here.
Sure.
It is that map is the same redlining map, and I've done it in every city. It looks exactly the same. If you do school quality scores or asthma ER rates, or I mean, I had done that map enough that I could tell you which neighborhoods were going to be the problem ones for COVID in San Francisco, because I had looked at the map enough times that I could have drawn which census blocks are going to have the problem, and they were.
Mhm.
So one is our constantly having to relearn that. You know where the problem's going to be. The other is that it's overlapping problems. So that same school quality map is the same asthma ER map, is the same unemployment map. So the same people who one group is trying to fix this problem for also has 17 other problems,
right.
and we are trying to each solve one at a time, and I don't think it works. So when we do collective impact and get everybody to the table and say, somebody do this part, do this part, do this part. The other thing is you have to have community at that table, because our understanding of each other is not great. Even if
Yes.
we think we have something in common,
It's true.
knowing which of the 17 usual problems are the problems here is not something you can intuit. And if you are not asking, you are not going to know. And then you're going to solve problem A, and really D is the one that's causing all the real issues. And so getting a real understanding by having the folks who are impacted at the table, not after the fact, but during the problem definition,
Sure.
and then making sure that you have at least some richness to who is at the table trying to solve the problem, so that you're not trying to just move one lever.
Thank you. So, Mr. Secretary, you and I were just talking 2 seconds ago about this issue, and I asked you, I said, how many rural hospitals in Virginia do we expect to close? And you said, well, there have been a lot of announcements. So as we think through the patterns that exist in Virginia, there's a huge divide in terms of access and outcomes related to Northern Virginia, for example, and to rural Virginia. So can you explain, what do you see as sort of the intervention that could help close that particular gap between those two regions and some of the outcomes we're seeing regionally across the state, especially with these, you know, hospitals announcing that they're potentially going to close?
I think it's money, right? So like, what do we do in a situation where the resources are going away? Those disparities already existed from the beginning, and you're having to convince people to invest more. And so that is the challenge that we even have right now in Virginia, right? We are still working through our budget because we're trying to figure out how much revenue we're going to have, because that determines then how much investments we're going to be able to do. And everyone is okay with helping until you realize that sometimes investments means that you have to have enough revenue to do that. And there's only but so many ways you can raise revenue. And so we're having that conversation in Virginia. It's also true that you could figure out different ways of doing healthcare financing. So we are losing some through the big beautiful bill, but there's others that are still available, but they take some time for us to be able to structure them in a way that provides some of the revenue that is necessary to make those gaps go away. And so we're trying to figure that out as well. And then you have to also realize too that, and this is hard, and I've heard this by federal authorities say it out loud, is that some places just can't sustain hospitals. And in those situations where we know that those places cannot sustain hospitals, given the federal retrenchment, is they still deserve access.
Mm-hmm.
So then what does that look like?
Right.
And I think, again, that is a tough question that we're trying to answer right now, because some people have to drive to North Carolina from Virginia to get care, or West Virginia, or other places, Maryland, right? So we're trying to figure that out right now. So I don't have a direct answer.
Sure.
But what I could say is, like, I think that is what every state right now is grappling with, is like, in the absence of X, how do we still ensure that people are treated with dignity and respect?
Right, absolutely. So in Maryland is a relatively wealthy state, but outcomes, again, we see diverge dramatically depending on race and zip code. Just curious how you're thinking about interventions, and what do you think might be one that could really address that gap there?
Yeah, I think that the key is having interventions be place-based and in communities. So Governor Moore, one of his key priorities is ending child poverty in Maryland. And so we have the Enough initiative, which is engaging neighborhoods, organizations, unions, government, and households.
Everybody.
Yeah, right. In combating child poverty. And so
Yeah, because it's everyone's challenge. I mean, and everyone has to be at the table to solve
kind
it.
of determines where they want to invest that money. So to some of what you were saying about, it could be schools, it could be housing with the mold causing asthma, it could be food, and different communities are identifying what they want to focus on to ultimately raise that community, and that will then have the impact on various metrics. But I think to tackle something in isolation is not, to your point, like you squeeze one end of the balloon, the other end of the balloon opens and so expands. And so it really is, I think, about what can help a community to feel supported. And that's like what we have these produce prescriptions that the Enough communities are figuring out how they want to utilize for healthy food. Because each community is different in terms of how they would utilize food, where it would be utilized for, who they would target it for. And we are enabling that flexibility because each community is unique and has differences to make sure that we're really getting at, in this case, the root cause of poverty.
It's interesting you say that, because I remember, I did communications in the White House a couple of times, and often we would say this bill is going to lift 50% of Black people out of poverty. And I eventually got to the point where I said, I'm not saying that statistic anymore, because it's not real. Like, I live in the hood. These people have been here for generations. Like, when we get to the issue of trust, this is why there's this gap and this divide, is because you're saying things and doing things that don't connect to people's reality and their lived experience. I'm curious though, if you do the place-based, does that mean you have, and this is an exaggeration to really make a point, potentially 50 different strategies that your agency then has to manage and reconcile and, and manage to the point of having real outcomes that the governor can say that this actually worked?
Yeah, no, I mean, you raised, that's that balance that you need to have, where, there are some fundamentals to how the programs work so that you can evaluate them, but then enabling, it's almost like a menu for different communities to be able to choose from. Because yes,
got it.
I mean, I think alignment is really key.
Sure.
I would say, coming back to just healthcare, in one of my prior roles, right, leading quality improvement, we had this spreadsheet, this huge spreadsheet, like 8-point font of the 500 quality metrics that we were being held accountable to for the different payers and the different programs. And I was doing clinic every Friday. And I mean, I am the ultimate dork. I'm an MD, PhD, and econ policy expert. When I was reading my patient's charts, getting ready for clinic the next day, I wasn't paying attention to, oh, well, that patient has Blue Cross Blue Shield, so I'm going to be held to this quality metric, and this other patient has Aetna, so I'm going to be held to that quality metric. If I'm not going to do it, who's going to do it? Nobody. And then what happens? everyone's like, well, let me just go back to doing what I do.
Yeah.
And you don't have that momentum that you need to really drive change where people can then see the impact of what they're doing. So I think, to your point, it's important to have flexibility, but there also needs to be overall alignment of what is the direction that we want to go. And this is where, when I was at CMS, we did a lot of work on aligning quality metrics across our programs to try to end the insanity of is controlled diabetes a hemoglobin A1C less than 8 or hemoglobin A1C less than 9? Like, why don't we just help someone with their diabetes? Why are we spending time arguing about that? So I think that's kind of, where you can kind of strike that balance.
Yeah, feel free to clap on that one. Yeah, there we go. Don't be shy, audience, okay? We need the energy. Don't be shy about it. Thank you for that. So what makes this conversation so powerful is that we have all three of you here. We were representing the entire region. So I'm curious what level and to what degree, to your point, Mr. Secretary, you have people that are traveling to Maryland to get healthcare, to get certain services. I'm sure each of you could probably say the same thing. So that sort of begs the question, how are you guys collaborating across, what for many of us is false sort of territorial lines?
Yeah.
To address some of these big
very
health
little about
challenges.
health respects state lines. They don't care.
Right.
Can't even get our health institutions to do it for the most part. So I think we do a good job collaborating on some things. We had everybody on the phone for the sewer, so on the sewage line break. So we when we have to, we collaborate well. I think in the instant of particular things, we do well. I don't think we've planned and thought together as much, but that is really difficult to do because everybody has their own pressures. Everybody's political environment's quite different. Everybody's care environment's different. But I do think there are some areas. So data is one where, as we restart some of the things that got stalled on the federal level around data sharing and interstate data sharing, I think we're going to get to a place where we can actually reflect in our data the way people are actually behaving. My kid does not get reflected in the DC immunization data because I lived a block from Maryland, and so all of his care was being done. I'm like, okay. They're like, try our app. I'm like, I'm not in your app, and I'm the director. So we have to have some areas where we can do that, and I think looking at workforce and how we kind of normalize our rules a bit so that people can be as mobile as we see they already are. Data, I think there are some areas where we can expand what we're doing on the emergency and preparedness side where I think we do quite a good job.
Doctor?
Yeah, you mentioned the Potomac interceptor. That's a perfect example of how in that emergency situation, there's a lot of collaboration. To build on what you raised about data, for Maryland, we have a health information exchange called CRISP, Chesapeake Regional Information, there's something for patients, System for Patients. CRISP actually extends beyond Maryland. It extends into our neighboring states because, again, trying to bring in data of where people get their care. So that's an example, I think, of where we do cross state boundaries in a very powerful way. And in fact, CRISP is now being adopted by other states like Kentucky, Illinois is looking into it, Connecticut, because Alaska, because it is such a powerful platform. I think another area that you're seeing increased collaboration across states is the areas where the federal government is no longer leading. And I think public health is a perfect example of that. So now with the changes that have happened with vaccine guidance, with the U.S. Preventive Services Task Force not meeting anymore. In the Northeast, we have the Northeast Public Health Collaborative, where all of the states in the Northeast are now part of this collaborative to talk about vaccines and preventive services and how do we align on evidence and guidelines and even things like talking about supply chain. If supply becomes an issue, you have the Governor's Public Health Alliance as well at the national level, bringing states together. And so I think that's another area example of where in part because of what has happened with the federal government, you have increased collaboration among states.
Yeah, so definitely data. I think right now we're pretty good at public health by and large. I remember during COVID, I worked for Governor Northam, and we'll be on the phone with Governor Hogan and Mayor Bowser trying to figure out how do we vaccinate, given the fact that folks cross state lines all the time and then work in different places, live in different places. So that's a really good one. I do think we have to be intentional about it. So even while we were sitting for dinner, is thinking about our rural transformation fund dollars and how do we talk to each other, since we do have rural communities that bump against one another. And so after this, we'll be talking more about that. I also think another area is procurement. It'll be really interesting, right? Because when you think about vendors, they tend to shop around in different states. And so what it will look like for us to kind of use our purchasing power together to get the best deal possible in an environment, again, that we're losing resources.
That's all good stuff. So let's transition into trust, which we can then get into vaccines, because I've just found this whole thing to be so incredible. The politicization of vaccines, especially, first year of working in the White House during COVID, it was just incredible what we were up against trying to convince people to take their vaccines and not potentially kill themselves and the people that they love. So let's talk about the role of trust. Trust has become one of the most important and least visible drivers of health outcomes. Low trust equals the worst outcomes in too many respects, too many regards. We know that trust is significantly lower in underserved communities, and the lack of trust directly affects whether people seek care, whether they follow guidance, or engage absolutely at all. So from all of your perspectives, I'm curious, what do you think are the main drivers of distrust among underserved communities? And then what are the most effective ways to rebuild that trust and make it more sustainable?
Well, I've always called this earned mistrust. We earned some of this.
Yeah.
So I think the biggest driver is accurate historical memory, which is unfortunate, but really, your grandma told you, and she was not incorrect. I think that is a thing that we can get past, because
Can get past.
I think we can get past it, because your grandma had a story, but your mom's going to have a story, and your auntie's going to have a story. So it is almost always about the last thing we did, not what we used to do. So if we can do a demonstrably better job, I think we benefit from the fact that people can't help but give us a chance, because they have to. They have no choice. It is very hard to avoid us completely, because people want to get well. They do. They may not engage us in the way that we want them to. I may not find you until I wish we had been managing your diabetes, and instead we're cutting off your foot.
Sure.
But can we do a good job with that? Can we take care of your family? Can we keep you from getting the next thing? Can we? So the way in which we really work with our workforce, we look at cultural congruence, we get out into communities where people can see both our healthcare providers, our public health community in a non-emergency way. The way in which we invite the next encounter, I think we have some room to do better. And in some ways, I think we have, because if you look at a lot of what we're calling, there's a reason we're calling it vaccine hesitancy and not vaccine refusal. Because people waited, but then they went. They just wanted to see who was in line first. They wanted, and I think that's legitimate.
Yeah.
Because when we've asked people to be first in line, sometimes it was because we were about to do something wrong.
Sure.
So I think we have a chance. I am hopeful that we have done enough with the approaches to healthcare. That's not just about telling people to be nicer people.
Sure.
We did a lot of telling each other to be nicer people that I think was, for the most part, useless. But when you actually are holding people to account,
Sure.
I think when we get to that point and can prove that we're doing a better job, I think we have a chance.
What do you think the role of implicit bias plays in delivery of care, and how does it connect to trust?
I find that really interesting. It plays a role. So One of the things that I spent the earlier part of my career on this was drilling that down. So we could see that when we wanted blood pressures done, that if you were Black, you were less likely to get the repeat blood pressure. People just weren't doing it. But then I could drill down to see that that was a particular 3 people. And when we put it in their performance review, they stopped doing it. So we're going to look at the data and we're going to disaggregate your data and then see if you have a gap. And if you're one of the people with a gap, your goal is to not have a gap. The same thing when people were calling WIC. You get 2 calls if you were Black. You got 5 or 6 if you were Latino. Why they were doing that, I actually don't care. But if you keep doing it, it's in your performance review. So it comes down to, there is a bias, but do I need you to be a better person? That's the thing. Because we spend a lot of time trying to convince people. I'm not sure we need to. Just don't act on it.
Sure.
So, but that means you have to have the data. You have to be looking at performance. You have, we could tell within the 3rd week after the vaccine that we were not doing reminder calls to Black patients. By the 3rd week. And we closed that gap on people coming back in because we told them they were doing it and they cut it out.
In a city like DC, that's
No,
incredible.
that was San Francisco.
Oh, San Francisco.
Where they were assured that they were not doing that. Very confident. So, if the data is there, we have to actually hold to a standard. Inequality is almost always unequal quality. Whenever we are doing that, we know how to do it the right way. Somebody's getting it right some of the time. So why are we not hold that standard for everybody? And we have the data and the mechanisms now to do that. It's not inference. You can tell. So use it.
I'm curious, Mr. Secretary, what is and this is an obvious question, but I just really want you to answer it for me. What's the role of education? Because, my neighborhood in Northeast DC, by Heckinger Mall, oh, really? Okay, great. By the Denny's. Nevertheless, I could see my neighbors walk into the Denny's, right? No disrespect to Denny's. And, they would say, well, I don't know, I need a primary care doctor. Like, what's the value of that for me? Because so many people engage the system in the state of an emergency, a last resort, So I'm curious the role that education plays in reestablishing and rebuilding the trust and how your agency is going about addressing the issue of trust.
I was thinking about this on the way over here in 395 traffic.
You had a lot of time on your hands.
A lot of time on my hands. I solved every problem. I think about it in 3 ways, right? I think during expansion, one of the reasons why we couldn't enroll people fast enough is because they had been denied in the past. But we had to have an education campaign. We were telling people, come back this time around and you'll get the care and the access that you need, right? And so there is a certain kind of education that we need to make because so many people have been so disappointed by the system so many times that they're not willing to put themselves out there again.
Sure.
So that's 1. 2 is, I'm Honduran, so I have WhatsApp. I don't know if it's a 1-to-1 correlation. But the amount of misinformation that comes through WhatsApp.
Yeah.
And then by the time that you get to addressing it, it's already, the whole family is asking you whether or not this is true. And so that I don't have a response to because I do think that even educated people fall into that misinformation trap. And so how do you get to those folks early enough? And with a way that, with humility too, it's not, oh my gosh, you're so wrong and bashing them, but it is, let me present to you an alternative way of viewing this. And let's talk through it. It's a really important component of that.
And so much of it is cultural, right?
So much of that is cultural.
I'm like, why am I rubbing butter on the bottom of my kid's feet because she's sick, right?
And it's both, right? So for us, growing up, it was always Vicks.
Right. Cures everything.
So
or Robitussin, or Tussin, as they say, right?
Why is ginger ale solve everything? I don't know. But it was always Vicks, right? And we're from a village.
Castor oil. Right. We could go on and on.
It's always something. Right, and so Vicks for us was the thing, and I realized that in the village my mom grew up, there wasn't a physician, right? So they just made do what they have, but it's also not saying don't do Vicks, right. Do Vicks right? Because that is the process by which you get people to do better. It is transitioning them and also letting them know that it is this and not forcing them to make a choice between their cultural habits and what we know to be actually improve their health overall. So that education also matters there, and that cultural sensitivity.
Did you go through the 3 points?
Yes, it was a 3.
Okay, sorry.
VIX, what's that? And being reliable and kind of showing up for people.
The reliability. Okay, perfect. So let's get into disinformation around vaccines, because that's in the politicization of vaccines. I mean, this has been going on for decades. I mean, this is not a new thing, but when COVID hit, it sort of was, I found it to be incredibly remarkable. And I know you're leading on vaccine adoption, I guess, if that's the right way to characterize it. I would just love for you to give the audience more about how you're addressing this issue of vaccine skepticism, what initiatives and efforts you're putting in place, how are you tackling this issue, the issue of disinformation layered on top of it. Just curious how you're approaching it in Maryland.
Yeah, well, I will start going back to before I was secretary, when I worked at MedStar Health. And when the COVID vaccine was developed, as we know, there was a lot of hesitancy.
Right.
And particularly in Black and Brown communities. And so we took one of our mobile vans and had community health workers go to inner city Baltimore, to the senior living facilities, apartments. And this was the start of vaccination. And we had 2/3 of people get vaccinated because they just needed someone who was from their community to talk to.
Right.
To ask questions, to understand, to feel like they weren't just a number or an arm that was going to get a needle put in them, right? And so I think that is the foundation of anything else that you do, right? Because you can have all the science, you can have all of the data, you can have the supply of the vaccines and the syringes and the gloves and everything. But if people don't feel like they're being met where they are and talking to someone who they can trust, who gets them, who gets their situation, then all your efforts will only go so far. So I think that is like the first thing, where we really are working with our communities in terms of, sharing information about vaccines. From a policy level, we have been very clear from the moment that the federal government started to make changes to their vaccine recommendations that we were going to follow the guidance of leading medical organizations like the American Academy of Pediatrics, American Academy of Family Physicians, American College of Obstetrics and Gynecology. And so when the FDA changed their labels on the COVID vaccine, we issued a standing prescription order so that anybody in the state of Maryland could get a COVID vaccine if they wanted. When the federal government made changes to the hepatitis B dose for newborns, we issued a standing prescription saying, no, you can get that vaccine. And now Maryland passed a law that the Secretary of Health has the authority to create vaccine recommendations based on leading medical organizations as well as federal and state organizations. So, it can still include like the Advisory Committee of Immunization Practices. This is important because one of the big issues with changes in vaccine recommendations is that the vaccine recommendations of the federal government are tied to what insurance companies will cover. It was huge. When all the stuff started happening with the federal government, it meant so much. As someone who used to work at CMS, it meant so much to me that America's health insurance plans, the big association of health insurers in the country, came out and said, regardless of what the federal government is saying, we're going to continue to cover vaccines at no cost.
It's very important.
So what we have done in Maryland is said that we will have a list of recommended vaccines that insurance companies have to cover at no cost. So again, when you think about what are the various barriers to people being able to access the care they need and want, the information, so meeting people where they are, having clear guidance, and then also things like people can't afford $200 for a shingles vaccine, right? Like, and how do we make sure that people can actually get the care that they need financially?
Yeah. Did you want to add something?
I just
Dr.
would say I have been really gratified by the entire vaccine story. I actually find it a very hopeful one.
Okay,
In
let's hear
that it is,
We need a little hope.
it was really a master class in the limit of power. You can't make people do stuff.
Exactly.
Could you make every pediatrician in the country give some different set of vaccines because you are the government? No, you cannot. The profession was going to do what it was going to do. And so by the time the recommendations changed, there had already been months of organization around which organizations are going to be the ones who are going to put the recommendations out. The Vaccine Integrity Project had come together to do the research because there should still be ongoing evaluation of the research. All of the different state governments, we've had many collaborations and meetings about what the law needed to change to. So we all have a very similar list of authorities that we're going to use, and the text of the laws are all very similar. You know, everybody, Walgreens was talking to everybody about how they were still going to do X, Y, and Z, and this is what I needed to say. The insurers, you really can't make people do stuff very well. And so if we all stand together with what we want to happen, you know, there is some confusion for people. It has been not a good system and we shouldn't have done it. But in the end, the loss has been far less than was projected or which was desired by the people who made those changes. It landed like a nothing burger, to use their language.
It was interesting because I was in the White House the first year, well, maybe the second year of COVID. So the first year of the administration, second year of COVID. And we were racking our brains around this issue of trust. So of course, you know, the vice president's like, we need mobile units, go where people are, meet them where they are. I mean, but to your point about the limitations of power, it was when we, you know, in those meetings, realizing the limits of the power of the White House in that moment. And so we were, you know, almost relying on the professionals on the ground to do the work that we could not do as a White House. You know, because there were all these forces up against us, right? It's like we're saying take the vaccine, someone saying take the bleach. It was all these conflicting messages that we were giving people. Meanwhile, people are dying around you. I mean, it was just it was just a chaotic time. We're trying to get shots in arms. I mean, all kinds of things. And so anyway, so I just wanted to punctuate your point by saying it was very clear to me being in that building, like the limitations of that building. And it was the first time, interestingly enough, that I've been doing this for 25 years, that we were going through what the rest of the country was going through. So in the midst of it, my kid's not in school, my dad gets COVID, goes blind. I mean, all kinds of things happening. So we're managing a situation while we're all, immersed in it and affected by it in equal same ways. It's just an interesting dynamic. And if we didn't have the doctors and Dr. Fauci and others who were doing this work on the ground, who had been doing the work well ahead of, COVID actually, I don't know what the right word is. I wouldn't say arriving, but I don't know what kind of a situation we would be in without professionals. So
I think that's rooms like this where I think the reality is all those people trust somebody, most of it. Most people trust somebody. And so they trust their own doctor. They trust the nurse at school. They trust the pastor at their church. And so what we learned during COVID is not to try to make them trust us. But to try to talk to those people so that they were armed with what they needed. Yeah. And so as all of funding and all these changes have weakened the on the ground connections to those people, as you weaken the public health department, as you weaken the local WIC office, then you lose any connection. So then the government has even less ability to do those impacts on the ground,
Sure.
because they need my connection and I need her connection and she needs,
Absolutely.
like, that you break the chain.
Yeah.
And then we are even more powerless in our institutions to actually make any change on the ground.
Sure. And the only way we could instill trust is to like put the vice president on television and watch her get her vaccine, right? That was the only way we could actually do it. Otherwise, we were again up against a lot of forces. Let's transition really quickly. We're about to transition to audience questions, but I want to talk about this issue of resources, because it all comes down to resources, as you said, Mr. Secretary. So I'm curious, you've spent your time, White Houses, Capitol Hill, you've been a little bit of everywhere and have had a really interesting sort of purview on these challenges, and not just the challenges, but how you solve some of these challenges. So I'm curious, I want to hear from all of you, but I'd love to start with you about sort of what are the best practices, how across public, private, and community sectors working together to solve and advance equitable health outcomes and solutions.
Yeah, I think, I don't know, maybe I'm a simple person, but I realize that bring people together around a goal, right? So the power that I have as secretary is the power of convening. So by and large, if I tell someone to be at the Capitol and we're going to talk about X, Y, and Z, they'll show up. And so then the thing that I have to do is show up for what? So we're going to show up to talk about eligibility systems and how do we make the friction less. And then you have to then also guide the conversation. And I found that to be the case in all of the settings that I'm in, right? If you want to do a bipartisan deal on Capitol Hill, we're going to talk broadly about X, and then you try to figure out where is the middle spot that everyone is willing to agree to that actually leads to some of the change that you want to see. At the state level, is the same thing, right? It's like, what can insurers, hospitals, and physician groups agree to? Not much, but there is something there.
Sure.
And so you have to be willing to use that convening power and also use the capital that you have at the moment to be able to bring people to the table. But you have to be specific at the goals. You have to have the right people, and you have to do the work beforehand.
Mm-hmm.
So what people don't usually do is that they bring people to the table and expect that table to be set. You have to do it beforehand. So you do an individual meeting to ensure that it's all choreographed by the time you get there, or else you risk bringing people together and having nothing to show for it.
So we've got a very diverse audience here, Dr. Bennett, and you talked about how you've been on the phone with sort of philanthropy over the last year, trying to bring people to the table. Tell us a little bit about what you sort of think of the ideal partnership collaboration looks like, and how do we actually get there? Because, a lot of these people could be brought to the table, your table, any of these tables, to be part of the solution.
Most of the complex problems we're dealing with are going to require public health, healthcare, and philanthropy at the table. And I mean governmental public health for that, but also there's a larger community around public health. So government and public health as an entity can bring a preventive and community lens, but that's only as good as the restrictions on the funding that I have. So if there isn't some innovative and more flexible edge that philanthropy can bring, it really does limit the impact we can have.
Mm-hmm.
And I think the degree to which healthcare and public health can both be at the table to talk about that whole spectrum. I've always said that when we focus entirely on preventive health, we've just decided that for some Black and brown communities, we've lost interest in you after you turn about 35 because they already have something. So if you're going to talk about whole communities, you have to be able to talk about them as children, as sick. You got to be across the lifespan and across the different levels of wellness. And so I think those three groups
Mm-hmm.
ideally should always be at the table together, and payers and religious groups, there are others that can come that also can be included, but I think that's the three-legged stool for me.
Mm-hmm. Dr. Teshimani, I'm curious how you're doing this in Maryland, if at all. Are you building a big table of partners to solve some of these problems? And who are those folks, and who do you find value added at the table? Just curious how you guys are bringing more, these three-legged stool together to solve some of these big problems.
Yeah, and I would actually add, maybe it's not a stool, it's a table, because I'll add a fourth leg, which is business, right? I mean, there's the business of healthcare, because healthcare is the #1 employer in lots of communities. There's also, coming back to where we started, about how in a crisis there's innovation. I mean, there is huge entrepreneurship in healthcare and huge opportunities there to tackle the problems that we've been talking about in a way that businesses can really, take charge of and be very excited about. So I'll give 2 examples in Maryland. One is, I'll come back to implementation of HR1. From the beginning, we in Maryland have been very deliberate about bringing setting a wide table between healthcare industry, other businesses, because, right, if people don't have healthcare, they don't show up to work, or they show up and they don't work well, presenteeism, absenteeism, philanthropy, technology, because of finding ways to be able to implement in the most effective way, various patient and community groups. We brought all of them together, but equally important, who was the we? It was me at the Secretary of Health. It was our Maryland Insurance Commissioner. It was the Executive Director of our Health Benefits Exchange, our Obamacare platform, and it was our Secretary of Human Services. So similarly, to come back to what Secretary Figueroa said in the beginning, it was also on the government end that we wanted to make sure that everybody knew that we were all working together, because people don't divide themselves into, well, this is the Department of Health part of me, and this is the Health Benefit Exchange part of me, and this is the Human Services part of me. So I think that has really garnered a lot of momentum to be able to develop good outreach and education for people as they are going to be navigating the changes, to get the support of some businesses to help us figure out how we can improve our eligibility and enrollment. I think the second example that I would give is our payment model. So, I mentioned before, Maryland has a unique payment model where all hospitals have a global budget that they are given, and the payment is the same regardless of what insurance a patient has. So that has a very dramatic impact of aligning care, because there now aren't the well, I just need to get more patients in this commercial payer who's going to pay me more, and I get paid for heads and beds. So yeah, I want to do that preventive stuff, but I also want to make my bottom line. So let me make sure that I'm continuing to grow volume in my hospitals. That has similarly required bringing payers, physicians, hospitals, businesses, because who pays premiums? It's largely businesses, Marylanders, so that we can figure out together how we can provide better care at lower cost to keep premiums down and keep care more affordable, so that we're successful in this model, because this model is predicated on saving money. So that's another example of where we bring everyone together. And I will say, they seem to be diametrically opposed, where I'll be in a meeting, I'm getting a text from one person, I can't believe they're saying this, I can't believe they're saying that. But then you come back to the common goal that everybody has. Anybody in healthcare ultimately wants people to be healthier. And it's a question of how do you, now this is Mina, the economist speaking, how do you align the market incentives so that that's what's rewarded? Because at the end of the day, organizations have to function in a market. And that's where you can really bring people together and say, okay, at the end of the day, we all want care to be affordable, because otherwise you'll be sitting in your office waiting for a patient to come in and you're not getting the patient because they can't afford the care, right? Or you have a pharmaceutical company doing some innovation, but if someone can't actually afford the drug, then they're not able to benefit from the innovation that you invested in. So again, really coming back to those common goals around affordability and access and being able to improve health can enable you to find, as Secretary Figueroa said, that kind of sweet spot, that middle ground, where nobody got exactly what they wanted, but everybody is good with where they ended up.
I want to follow up on that, your point about bringing business to the table, because I'm curious how you effectively do that. But let's take this time now, if you have a question, to go to the mics. See that little, oh, Wait, oh, perfect. We already got one at the mic. Perfect. Two at the mic? Even better. Perfect. So let's just go to their questions and then I'll follow up.
Okay, thank you. Can you hear me? Great. Hi, I'm Samantha Alanis from Illinois, and thank you for all your insights. I'm glad you brought up implicit bias, because I used to work for a healthcare system in Illinois, and I led DEI and health equity work, and I regularly get asked, like, can you deliver implicit bias training? But I felt like often implicit bias training puts the onus on the people harmed to give the benefit of the doubt to the people causing the harm. And so what I would actually deliver was, let me tell you about health equity and cultural humility and help you grow your emotional intelligence and compassionate communication skills. And I would bring up examples of what are things we commonly are taught that we have to unlearn, be willing to unlearn and relearn. And one example is that medical schools, nursing schools are still often teaching that Black people experience pain differently than white people do. And they're often not taking women's pain seriously. And if you're a woman of color, even worse. And when I would talk about that, I would have nurses of color say to me, I graduated in 2018 and they still taught that Black people have thicker skin than white people. And so, like, if this is still being taught, you have older faculty that are teaching in medical school and nursing school. What can we do to influence that change, where it's not just like assuming people have implicit biases and so you didn't mean to be racist and so it was just an accident, right? But more like holding accountable, like to unlearn and relearn that is medical racism. Thank you.
I think when people get specific, they get something done. So as long as people are talking vague principles, it is hard to change anything on that. But when we get specific and we say that GFR is based on a flawed racist idea and then stop doing it, you know, MedStar's seen a couple years difference in wait times for renal transplant. Like, that person's alive and they would have been dead. That's our goal, not be whatever person you are, but I need people to drill down. And so getting that expectation out there that there is some problem in your area, you find it. What is the area that you're in? You're an educator, great. Let's find the stuff that you've got and then motivate the constituency, in this case, students. They will find it if they are given an invitation and motivated and told that if they find it, we will fix it. The same true for patients, and the same is true for staff when it is something internal. So I think if we invite people into the conversation, those people all knew that was true, and yet their school still does it. So where was the mobilization to get that out of the curriculum? I think we need to invite that mobilization, because people know what it is. They just need to be motivated and feel supported to call it out, and then feel like that creates an obligation to fix the problem in the institution they're speaking to. We can help create that obligation.
I don't know if either you want to add to that. Okay, perfect. Next question.
Hi there, thank you so much for being here and talking with us. My name is Joshua Carrasco. I'm from Texas, and I currently am in my last year of pediatrics residency at UCSF, soon to be an adolescent medicine fellow at the Children's Hospital of Philadelphia. So I have...
Congratulations.
Thank you so much.
Can we give it up? Congratulations.
I will not quiz you on who's still there.
And I'm a Texan from Houston, so I had to shout that out.
So I have the significant pleasure of working with our nation's future, and so the talk of preventative care, positive health outcomes are the core of my interest in medicine so far. The realities of which are that as a trained fellow, so someone who will spend 3 additional years in training to become an adolescent medicine physician who works primarily in preventative care, sexual health, reproduction, substance use risk reduction, mental health care, things like that. I will be paid less throughout the course of my career than I will if I were to be a general pediatrician, by a factor of more than $1 million across my career. This is a reflection of the deprioritization or the under-prioritization of preventative care within our healthcare system, a broken model, unfortunately. We reward, maybe not reward, but it is a profitable system for disease, which I think is a component of the distrust among physicians. You know, it's a thought that like, we want you to be sick so that we can get paid. I don't think anyone agrees with that, but I think that that's the vision. And unfortunately, pediatrics is at an all-time low in terms of the applications into the field and then into the specialization through fellowship because of these financial unfortunate tunes, whatever that may be. So I guess my question to you three might be, what are you doing or what do you plan to do in order to make preventative care a reality or something that we can actually achieve? Given the actual reality is that like the number of people who are doing this work is shrinking because of the reimbursement model that we have in place that again is not prioritizing preventative care. I am taking that financial risk to do what I love, but others are not willing to do that. And so, what are you doing, or what will you do to make this a sustainable model? What can we do to change these larger beasts of bills, Medicaid, Medicare, to reflect that prioritization of preventative care to make it sustainable?
Thank you.
I can start.
Yeah.
Thank you for raising that issue, because I think it really is an incredibly important one. Before I became Secretary of Health, I ran the Medicare program, and this was actually one of the things that we sought to address. So we created in the Medicare program advanced primary care payments for when a primary care provider has extended hours, being able to include community health, other such services. We also created payments for things like care navigation, community health integrated into a primary care plan, and training family caregivers to care for their loved ones. So, where you do things in Medicare, a lot of times other commercial payers follow. And so, that was a very conscious decision in the Medicare program to try to increase reimbursement for primary care. Here at the state level in Maryland, part of our payment model, the AHEAD model, is a primary care investment target. So there will be a target that across all the health insurers that we need to meet to demonstrate that there is investment in primary care. In addition, we have payments like what I was talking about, this Population Health Improvement Fund, where we are able to invest money in prevention and primary care. Because I think you're right, the traditional way of payments has been skewed toward not only specialists, but procedural specialists. And so I think there are efforts underway to try to address that, and I think that's something that needs to continue.
I don't know if either of you would like to weigh in on this issue.
We're pursuing some of the same things and still looking at how to do a rebalancing of where primary care sits in the payment structure.
Okay, wonderful. Thank you for your question. So one last question, they're kicking us out of here. So one last question, and whoever can jump in and answer it, and then we'll close out with one last closing statement. Madam?
Hello, thank you very much, and I will be brief. My question is, we are talking a lot about changes, right? Like a lot of structural change, a lot of systemic change that we're experiencing, those of us in public health and community well-being in general. My question is, what interventions are we thinking of, imagining as far as well-being, as far as professional development programs for those of us in the field, right? Those of us that are now mitigating a lot of changes. What can we look for, and what type of, again, professional development or well-being programs and structures can we look forward to? Thank you.
Thank you.
So I don't know if I have a straight answer for you. What I will say is I think it is a good opportunity for you to educate us on what is necessary. Being a person who's a practitioner, as to what creativity you think we should bring to bear, given the challenges that we're facing. And so I will put the onus back on you to some extent to kind of educate us on what you think will be necessary for this new world that we're going into. I also think it's true that I don't know if we know the innovations that are ahead of us just yet, because this is 5 months in, 4 months in, into this new reality of losing all these resources. And so those innovations are coming to bear. And again, I think it's a collaborative effort to figure out what's next.
I will say we did a lot of work trying to recover from COVID. Public health, healthcare, we lost a lot of people who just, for various reasons, I think primary among which was exhaustion, decided to go do something else with their lives. I'm kind of looking for some of those nurses to come back. Everybody can't run a soap business from their living room. Everybody's got to come back somewhere. So I'm hoping we'll get some of those back. But at the same time, a lot of those people, that means that a lot of who's here now are new. A lot of people in my department arrived during COVID. So the department they're in is very different than what everybody else was used to. So it's going to take time to figure out what you all need to feel supported and what you're looking for. Because I think a lot of what we used to do in our model, one, they failed under the pressure of COVID, but many things would have. But also they weren't meant for you. They weren't built for the folks who are there now. I do think we're going to have to ask and rebuild because we have to learn it. It's different now.
Wonderful. Thank you for the question. So as we're leaving, I would just love for each of you to talk about something that you're working on right now that this room can connect with and support, and how they can support your work.
Well, one thing I think I need is to have a formalized way for that three-legged stool to get together. So we're looking at starting a public health foundation and really figuring out what's the structure and goal for that. What is it we're trying to achieve? I think it's going to be lots of little projects within there, but we need a system that can survive this kind of banding about we've had in the last year. You know, I've got less than 200 HIV cases after really decades of effort. To have someone say, we're going to cut all of your prevention funds, that is a lot of investment to throw down the toilet. So we need to be able to stabilize, to withstand these kinds of whirlwinds and not lose all the things that we've gained. So that's what we're looking at right now.
Good stuff.
In the spirit of apocalyptimism, I would say that we all need to link arms and work together and help our communities in navigating all of the change and uncertainty that is before us. Because I think, as everyone has said, we can sit up here and talk about the science behind vaccines or about what you need to do to stay enrolled in Medicaid. But that's not going to make the difference and the impact that we all want. It's really, all of us together, getting out into the communities, seeing where there are gaps, bringing ideas forward and really partnering to be able to have the positive impact that we want.
Yeah, I moved to Virginia. It's the best place to live and work. I think is help us figure out how to turn programs into systems. I think that's what we're challenged with right now, is how do we figure out how to take all these different things and turn it into something more efficient and more effective that reaches people earlier and gets them to better. I don't think that's something that government figures out on its own. It requires partners to come to the table. It requires honest conversation. It requires reinvestment. It requires us making a tough call, but it does require us coming to the table with that perspective in mind.
All right, with that, thank you to our panelists for a great conversation. Thank you, it was great. Well, when I know nothing about healthcare, you.